You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is February 17th, 2025. Our topic today is Abbas Chapter 21 about congenital immunodeficiencies. This is presented by Dr. Nikita Raje. She is an Associate Professor of Internal Medicine and Pediatrics and is the Chief in the Section of Allergy Immunology at Children's Mercy Hospital.
We are talking about Chapter 21. We are just going to cover the congenital immunodeficiencies. This chapter also has discussion about secondary immunodeficiencies. We're not going to cover those, and I'll leave that for your self-reading. And we'll just concentrate on the first part. That itself is a pretty long discussion. We used to have like maybe a couple of chapters for a couple of lectures for this chapter, half a chapter, because I'm not covering the secondary immunodeficiencies. But this time, since we are going to have a clinical series, I tried to cut down and just concentrate on Abbas discussion for these congenital immunodeficiencies. So let's get started. Today is February 17, 2025. I'm Nikita Raje from Children's Mercy, Kansas City, UMKC. We'll be talking about Chapter 21 from Abbas textbook, and the topic is congenital immunodeficiencies. Here are my disclosures, nothing relevant to the talk today, and will be just kind of a refresher on what we have studied throughout these several weeks. We talked about innate versus adaptive immunity and how there needs to be that first signal, which is the antigen or the microbe itself that interacts with the antigen receptor on the immune cells. And then for the adaptive immune system, there needs to be that second signal where the innate immune response provides a danger signal and tells the adaptive cells that there is a real concern and yes, they do need help. And that's called co-stimulation, or the second signal. Once there is a first and second signal is when you have activation of those lymphocytes or adaptive immune cells that lead to lymphocyte proliferation, differentiation into effector molecules, and then we get the immune response. Compared to that, innate immune response is ready to go and is activated right after the infection, and so it can respond within hours of the infection, whereas the adaptive immune response takes days to develop. So we talked about the various components of innate immune system, including physical barriers, cells, and proteins, whereas the adaptive immune system is made up of B and T cells. Now, depending on the type of microbes, the type of immunity that's provided by these immune systems differs. The innate immune response may stay similar, but looks like if there is a viral infection, for example, there might be natural killer cells that might be taking part, or a complement system might make membrane attack complex. And then depending on the type of microbe, whether it's in the extracellular phase, whether it's intracellular and phagocytosed, or intracellular, that is affected, that affects the type of immunity that's more active. For extracellular microbes, humoral immunity might be more significant compared to phagocytosed microbes in macrophage. Cellular cytotoxicity in form of helper T cells or CD4 cells is more active compared to intracellular microbes, where cytotoxic T cells or CD8 T cells are more active. Based on the part of the immune system that's affected, immunodeficiencies or inborn errors of immunity can be classified as defects in innate immunity or adaptive immunity. There are various ways of classification. This is the classification that Abbas uses and talks about the innate immune defects as listed here, versus compared to the adaptive immune response defects that are listed. Now, this is the different type of classification given by International Union of Immunological Societies, or IUIS, that updates the classification every couple of years. The previous classification that I have details on or listed here is from 2022, that gave about 485 immune defects. You can see over the years how the number of genes that are known to cause immune defects have increased, and from every couple of years when the update comes out, there are at least a few or more new immune defects added. So in 2022, the defects in red, the numbers of defects in red are denoted for each of these categories of immunodeficiencies. This was in 2022. And then now we have the new classification. The update came out recently. This is from 2024 update classification from IUIS. That's still not in PubMed. So the paper is not completely out, but this is the paper, and that's actually available on IUIS website. The classification from 2024 still has the same 10 categories that were present in 2022 update, and you can see for each of these categories, there are several subtables that helps you kind of organize the type of defects in various subcategories. But overall, these immunodeficiencies can be categorized as combined immunodeficiencies syndromes, predominant antibody deficiencies, immune dysregulatory disorders, phagocytic disorders, innate immune defects, autoinflammatory disorders, complement defects, bone marrow failure syndromes, and phenocopies. So the first 9 categories are monogenic disorders where a single gene can, or a single gene is affected that can be that would be causing different phenotypes, versus the phenocopies are caused by somatic mutations or somatic variants, which means it's not a germline defect and cannot be passed on from one generation to another, or it's caused by autoantibodies. But it looks very similar to one of the genetic defects in the first 9 categories. So those are the 10 categories of immunodeficiencies. In 2024, about 555 inborn errors of immunities and 17 phenocopies have been described. These involve 504 genes, including the newer ones that have been added in 2024 since 2022 update are 63 monogenic gene defects and 2 phenocopies. We also know that apart from the genetic categories of immunodeficiencies, we should be paying attention to the phenotypes of immunodeficiencies, and they can differ based on the manifestations, infections being the most prominent presentation for several of the immunodeficiencies, but we know some other categories have non-infectious issues, such as malignancies, lymphoproliferation, autoimmunity, granulomas, or atopy as part of the presentation. So there's also another classification that's given by IUIS every couple of years that's updated. The last update I have is from 2022, and that goes over some of the algorithms that will not be discussing today, just because I'll be waiting for the newer ones from 2024 to go over those. But just kind of keeping in mind that when you are thinking of the IUIS classification, that gives you the tables of genes that cause various defects, and then if you're seeing a patient with, say, EBV infection, you want to know what kind of immune defects to think of, and that kind of phenotypic classification or algorithm is what we see in this paper. So let's think of a child walking barefoot on the ground and gets a splinter in the foot. What kind of cells are you going to be expecting to be there in the tissue that are ready to fight the infection. Say there is a bacteria or fungus or a virus sitting on that splinter that has now broken the first physical barrier, first line of defense of innate immunity, which is the physical barrier. So the typical cells that you think of are the sentinel cells. These are macrophages, dendritic cells, mast cells. So when those cells start to fight infections, they release cytokines or messenger molecules that go to the circulation and ask for help. Neutrophils come from the circulation to the site of infection to help in the fight of the infection. But also dendritic cells, which are our messenger cells, take the message of what kind of infection it is and where is the infection through the lymphatics to the lymph node. In the lymph node are our T and B cells, where that message reaches of what kind of infection do they need to be prepared for. So the T cells and B cells come up with this whole plan of how they're going to fight this infection. And in effect, there is interaction of various parts of the immune system here, where the T and B cells make a plan. B cells go to the bone marrow, make IgM, then switch to G, A, or E to fight infections, and the T cells can make cytotoxic or helper T cells that go to the site of infection and then help in providing immunity as well. All right, so with that, let's start with some of the discussion about some of these immune defects. We'll start with the innate immune defects, and the first one is for the first responders, which are the phagocytes. So let's talk about phagocytic defects. So there are several types of defects, quantitative and qualitative, which can cause immunodeficiency. So congenital neutropenias can be caused by various genes. Severe congenital neutropenia is caused by several genes. Cyclic neutropenia, Shrock-Van-Diemen, these are the genetic causes of neutropenias and different from neutropenia that's more common and more commonly caused by secondary defects such as chemotherapeutic agents that would cause neutropenia that is more commonly seen. There are some functional defects like leukocyte adhesion defect, chronic granulomatous disease, myeloperoxidase deficiency, specific granule deficiency, Chediak-Higashi, hyper IgE syndrome. The last two are not typically categorized as phagocytic disorders by IUIS, but they are definitely disorders where neutrophils are affected. So here we are including them in this discussion in phagocytic disorders. So let's think of these neutrophils. Neutrophils are like allergy immunology fellows. They are on call. They are on call 24/7 though, and they are in the blood vessel flowing through the circulation. But when they are called upon, or paged, they go and help out with the infection. So let's think of a physician who is on call and is finishing up work, going on the freeway, trying to get home, and what happens if you get paged? You're likely gonna move from the center lane of the freeway, move to the peripheral lane, slow down, maybe take an exit, and go back to the hospital to take care of whatever you're paged for. So same way, these neutrophils are in the circulation. They are flowing through the center lane. This is their freeway. They are in the center fast lane of the circulation and going about their business, but they may get paged or they may get the message saying they are needed, and so they have to slow down, move to the peripheral lane or slow lane of the circulation, apply brakes, and come out of their freeway, take an exit, and go back to the site of infection where they can perform their function. So let's look at that. Here's a neutrophils moving to the periphery, coming out to exit. And what happens if they cannot apply brakes? What happens if they do not have the molecules or adhesion molecules on their surface that help them apply those brakes and come out of the circulation? In those cases, we know of a defect called leukocyte adhesion defect, where the cells are trapped in circulation. So that's called leukocyte adhesion defect. Type 1, LAD type 1 is caused by defect in CD18, which is the prototype of this defect. So here is another picture showing the same process. Here is a neutrophil that has selectins and they have selectin ligands on them and integrins. And on the endothelial cell wall, so blood vessel wall, endothelial cells have selectins on their surface and integrin ligands, right? So leukocytes are flowing through the fast lane of the circulation. When there is an infection, the site of infection sends messages using cytokines to the circulation saying we need help, right? The sentinel cells that we just saw when there was a splinter in the foot, macrophages, dendritic cells, mast cells, they are the ones that are releasing cytokines because there is an infection in that tissue. They send these signals to the circulation saying they need help. The neutrophils that have integrins in low affinity state and selectin ligands on their surface are in the fast lane. When they get the message, they move towards the periphery so that they can engage the selectin ligand with the selectins on the endothelial wall. Selectin ligands, remember, these are all adhesion molecules, and when they bind to the selectins on the endothelial surface, they start rolling on the surface of the endothelial wall. That is like a slow roll, which means they slow down, but they are not coming to a complete stop. When they start engaging their integrins and bind to the integrin ligands or ICAMs, they come to a complete stop, but the chemokines help in binding to the chemokine receptors on the surface of leukocytes, so that the integrins can get into their high affinity state. So now there is interaction between three type of pairs of molecules. Selectin ligands bind to selectin, that was the rolling stop. Chemokines that are released from the endothelium are binding to the chemokine receptors on the cell, and that helps the integrins to come in high affinity state and bind to with high affinity to their integrin ligands called ICAMs. So when the integrins bind to their ligands, these cells come to a complete stop. So that's tight binding compared to the selectin binding that is a loose kind of binding that helps in making that rolling stop. Now the integrins bring that cell to a complete stop. Then they move through the endothelial wall, through the cell or between the cells, and come out of the circulation and move towards the scent of the chemokines, along that scent of chemokines, so that they go to the site of infection and help in killing the microbes. These molecules on the surface of leukocytes are integrins such as CD18 and CD11B or CD11C and CD18. So remember, integrins are two chains, alpha chain and beta chain. The beta chain is CD18 and the alpha chain can be different ones, CD11B, CD11C or CD11A. So these are the integrins, LFA1, MAC1, CR4, right? All of these integrins help in binding to the ICAMs on the surface of endothelium. So what happens when these are defective? So if there is a defect in CD18, which is a beta integrin, the disease that's caused by that defect is called leukocyte adhesion defect type 1. That's the most severe form that you know of as LAD. These patients present early in life. There is delayed separation of umbilical cord because the separation of umbilical cord requires the neutrophils to go and cause inflammation in the umbilical cord, and then that cord gets separated. Because there is no integrin, there are no neutrophils there is delayed separation of umbilical cord. There are wound healing issues and can cause skin and subcutaneous infection, but there is no pus formation because the pus formation needs neutrophils to come to the site of infection, kill the microbe, and get killed themselves. That forms the pus. Because there is a defect in the integrins, neutrophils are trapped in circulation, so they don't come to the site of infection. And so there are more and more neutrophils in the circulation because the bone marrow keeps getting a signal that there are neutrophils needed. They keep making neutrophils. Neutrophils come to the circulation, but they are trapped in circulation and cannot go or use their adhesion molecules to go to the site of infection. So that's your LAD type 1. That's the most severe form. LAD type 2 is a defect in Sial Lewis X. There is a defect in a GDP glucose transporter that helps in transporting fucose into the Golgi apparatus that helps in making Sial Lewis X. Because there is that defect in the transporter, Sial Lewis X is not present or is defective, which is your selectin ligand. Because there is defect in selectin ligand, selectins cannot bind to them, and so they cannot come to that rolling stop. So that's your LAD type 2. There are a lot of developmental abnormalities and growth retardation. There's also something called Bombay blood group here. What happens in these patients is for you to have a blood group AB, excuse me, A, B, or O, you need the core antigen called antigen H. For making antigen H, you need Sial Lewis X or fucosylation process. Because that's defective, the H antigen is not formed, so neither are they blood group A, B, or O, and those patients have this rare blood group called Bombay blood group. That's your LAD type 2. LAD type 3 is a defect in a protein called kindlin 3. There is a genetic defect in that makes protein kindlin 3. This helps in that process of changing low affinity integrin to high affinity integrin. That process is caused because the chemokine binds to chemokine receptor and from the outside sends a signal to the inside of the integrin molecule where it makes change so that the outside part or the domain of the integrin becomes high affinity integrin. So it's called inside out signaling. This defect causes infections but also causes a severe platelet defect because of which there is bleeding problem. Infections in LAD type 1, 2, and 3 give rise to different infections can in LAD, all of these can be related to poor wound healing, can include periodontitis or peritonitis and similar skin and subcutaneous infections. These patients typically need supportive therapy with antibiotics. However, LAD type 1 is pretty significant, can affect them and can be life-threatening, and the treatment is stem cell transplant. Chronic granulomatous disease.
Dr. Raje,
Yes.
For LAD type 3, when you say inside-out signaling, what exactly is that referring to?
So again, this is chapter 3. We talked about this where the chemokine binds to chemokine receptor. So that outside, that signal goes into the inside of the leukocyte and affects the conformation of integrins. So from the interior, that signal causes an outside change in the integrin conformation. So you see in this box here how the integrin is wide spaced and that binds with high affinity to the integrin ligand. So that's your high affinity integrin that comes from because of that signaling from the inside. So it's called inside out signaling.
Got it. Okay, thank you.
Chronic granulomatous disease, defect is in gene coding for FOX enzyme or phagocyte oxidase. FOX enzyme has various parts of it. Defect in any of them can cause CGD. The most common form is the X-linked CGD caused by defect in GP91 FOX. And then, of course, there are autosomal recessive forms of CGD as well. This defect leads to infection by catalase positive organisms like Staph aureus, Burkholderia cepacia, Nocardia, Serratia, Aspergillus, Candida, all kinds of fungus that can cause infections. Why catalase positive organisms? That's something I will leave for you guys to think about and let me know. If not, we'll talk about it at the end. Neutrophils cannot control these infections without that oxidative burst. So then they bring in other or attract other cells like T cells and macrophages, and that leads to formation of granulomas. Diagnosis is done by oxidative burst test or dihydrorhodamine test, and the treatment is triple prophylaxis. Interferon gamma that increases 91-FOX transcription and helps stimulates other FOX components, and then also antibacterial and antifungal prophylaxis. So that's your triple prophylaxis that helps in preventing several of these infections. The curative therapy is stem cell transplant, and gene therapy is available on research basis. Moving on to NK cells, we are still talking about innate immune defects. So GATA2 deficiency or monomax syndrome is a quantitative defect in NK cells. NK cells are low. Apart from that, there are defects in dendritic cells, monocytes, and B cells are also low. These patients present with severe viral infections, fungal, bacterial infections. We are talking about severe All right. We are talking about severe viral infections like herpes, disseminated infections by herpes virus, and things like that. Warts, GATA2 particularly can present with lymphedema and hearing loss. These patients are at risk for having cancers and pulmonary alveolar proteinosis. MCM4 is again another quantitative defect in NK cells. It is associated with adrenal insufficiency and growth retardation. CD16 defect or Fc gamma R3 defect is caused by loss of NK cell function, and so that antibody dependent cytotoxicity is affected. These again presents with severe viral infections. Toll-like receptors. Toll-like receptors, we know that they play an important role and are downstream of several different immune cells and signals. So defect in toll-like receptors can give rise to lots of types of immune defects. For example, MyD88 and IRAK4. These patients present with severe bacterial infections, present early in life. We know some of them can now present with even viral infections. Later in life, some of these defects become less severe. These patients will present with severe infection, say for example sepsis, and there might be lack of fevers, lack of elevation of inflammatory markers. TLR3 pathway defects, there are several genes that can be affected. These patients present with HSV encephalitis. All right, moving on to, more information about NF-kappa B pathway. So defect in NEMO causes anhydrotic ectodermal dysplasia with immunodeficiency, EDA-ID, right? This is just saying ectodermal dysplasia with anhydrosis with immunodeficiency. So these patients can present with encapsulated pyogenic bacteria, intracellular bacteria, opportunistic infections, viruses, all kinds of infections. Another defect is in IKB alpha. So this NEMO defect is IKK gamma defect. Another defect can be, this is X-linked, versus similar defect in IKB alpha is autosomal recessive form of ectodermal dysplasia with anhydrosis and immunodeficiency. So remember, if you notice anhydrosis and ectodermal dysplasia, you think of these defects. What does ectodermal dysplasia mean? Anything that comes from ectoderm. Hair, teeth, nails, skin, all of these come from ectoderm. So defects, so sparse hair, conical teeth, skin defects, nail defects, all of these can be a part of ectodermal dysplasia. Defects in IL-12 or interferon gamma pathway. Defects in some of these genes or this pathway. Remember, this is the pathway that's for intracellular microbes, right? We talked about these transcription factors and cytokines and the pathway, and if there is a defect in that, that can lead to Mendelian susceptibility to mycobacterial disease. Now remember, that's the name given. Some of these defects can present just with mycobacterial infections, but there are other defects that can lead to infections with other microbes, such as IL-12 defect or receptor defect can present with salmonella infection along with mycobacteria. Some of the more downstream defects can present with viral infections apart from mycobacterial infections. Defect in splenic development. We talk about congenital asplenia. These patients typically can be part of another overall anomaly called heterotexy, but there is also a genetic defect that causes congenital asplenia. Isolated congenital asplenia is autosomal dominant and is caused by a defect. At least one of them is known as this one called NBX 2.5 this encodes a protein in transcription regulation of splenic development, and once there is no spleen, there is a risk for severe infections with encapsulated bacteria. Give me 1 second. All right, sorry about that. All right, so we will move along and switch gears here. Any questions so far? We talked about several innate immune defects. Okay, let's move along, and again, we come back to this child walking barefoot, getting a splinter in the foot. The innate immune cells are present right in the tissue, macrophages, mast cells, dendritic cells. They do their job. Macrophages release cytokines. The first responders, neutrophils, come to the site of infection to help out. Dendritic cells also do their job, take the message of what kind of infection and where is the infection, get into the lymphatic vessels, go to the lymph node. That's where the T and B cells are. T cells are gonna get that message from dendritic cells if they're present. The B cells also get the message from another place, and they are gonna help out. But what happens if there is a defect in T and B cells? That's where you get combined immunodeficiencies. The most severe form of that is severe combined immunodeficiency, or SCID. So this is the figure from Abbas that goes over the development of T and B cells, and at each stage, if there is a defect, that can cause SCID. So stem cells develop into common lymphocyte progenitor, and that gives rise to either B cells or T cells, pro B cells or pro T cells, and that at that stage, these cells require enzymes like ADA and PNP for their survival, right, and their progression in this pathway. There are also some other signals that are required for survival of T cells, like IL-7, IL-2. Common gamma chain for some of these cytokines. Also the particular receptors for these cytokines, downstream signaling through JAK3, and enzymes like ADA and PNP. So the defect here in some of these can lead to lack of T or B cell formation. There are also these enzymes where the T and B cells require these enzymes for recombination, VDJ recombination, that helps in making BCR and TCR. So RAG1, RAG2, Artemis, Ceranose, DNA ligase, DNA PKCs, CD45, CD3 in case of T cells, and then in case of B cells, BTK, PI3 kinase, Blink, and several others. All of these are required for the making of the pre-BCR checkpoint or pre-TCR checkpoint, and then make the final BCR or TCR. So defect in some of these enzymes can lead to lack of B and T cells. Apart from that, if they go through this cycle or this phase of development and make pre-T cell and pre-B cell, they undergo various checkpoints so that the T cells can make single positive T cells, CD4 or CD8, or the B cells can go to the periphery and mature into follicular B cells, or marginal zone B cells or B1 B cells. So defect in the various genes such as coronin1, ORI1, STIM1, all of these, ZAP70, MHC class 2, and multiple of these can lead to defects in one or more subtypes of T cells. So there can be a lack of just CD4 or just CD8. In case of class 2 MHC, CD4 or ZAP70, lack of CD8 can occur. But in general, there are several defects that can lead to SCID that might affect one or all different types of lymphocytes. So that was just the chart in Abbas. Again, going through some more details. So what happens in SCID? These patients present pretty early in life without this newborn screening for SCID. These patients used to present with severe infections like bacterial, viral, fungal, opportunistic infections, protozoal infections, also vaccine strain infections. So even live vaccines could cause infections in these patients. That is the big reason why we avoid live vaccines in these patients. These patients can present with recurrent rashes, recurrent diarrhea, and failure to thrive. They cannot have growth without having a good immune system that keeps them healthy. So the big issue is the T cell development. Remember this chart from several chapters back, where the T cells are, as they go through development, they go through various phases from stem cell to probe T cell to pre-T cell, double positive T cell, single positive T cell, and then finally mature T cell. On the surface, it starts to make that pre-TCR in pre-TCR phase, and then starts making the full TCR along with having both CD4 and CD8 on the surface, which is the double positive cell, and then immature T cell can still have either CD4 or CD8 on it, which will finally mature to a mature naive T cell. At each stage, some of the molecules or enzymes that are important for that developmental phase are present, and so you have to know the defect can at various stages can cause various disorders. This is a chart again talking about various T cell defects causing severe combined immunodeficiency. You see the X-linked SCID caused by defect in common gamma chain and things like that. So I'm going to show you that in a little different way. Here are the subtypes or the phenotypes of SCID: T minus, B minus, and NK minus. Sorry, that's a typo there. There has to be a minus sign. So all three cells can be affected when the enzymes such as ADA and PNP are affected. If the most common form of SCID, common gamma chain or X-linked SCID, is caused by IL-2R gamma defect that causes T minus and K minus B plus defect or the phenotype. Downstream of IL-2R gamma common chain is JAK3, so it causes very similar subtype, but it is autosomal recessive rather than X-linked. So several genes that take part in VDJ recombination, if they are affected, they cause T minus, B minus, and K plus phenotype because they are needed for VDJ recombination in both T and B cells, but not the NK cells. So RAG1, RAG2, Artemis, ligase 4, PR, DNA PKCs, PRKDC, all of these can cause T minus, B minus defect. These are the SCID phenotypes that are radiosensitive, and the conditioning regimen in these gene defects for stem cell transplant has to be lower intensity, just because there is a defect in DNA repair genes, which means that they can lead to fatality just because they cannot repair. If um, some of those drugs are given, the DNA repair may not be enough for them to recover from that. Same for the radiosensitivity in this case. All right, there are some gene defects that cause just the T cells to be affected. B and NK are normal. That's IL-7 receptor alpha chain, CD45 defect, CD3 delta, epsilon or zeta chain. When they are affected, they just cause defect in T cells. CORO1A, AK2, Serenose, these can actually present with a variable phenotype. So T minus is required for all types of SCID, but some of these defects can have B cells or may have absent B cells, and they are all NK positive cell phenotypes. All right, here is some more information about some of these phenotypes. ADA defect is the caused by the toxic effects because the ADA that causes deamination of adenosine and 2-deoxydeadenosine to inosine and deoxyinosine. Because that pathway is not able to progress, these metabolites take an alternative path. So there is accumulation of the alternative metabolites, and those alternative metabolites can have toxic effects. So deoxyadenosine and its precursors, as mentioned here, can give toxic effects and inhibit DNA synthesis. And because lymphocytes have more of that recombination going on, they are very prone to toxic effects of these metabolites. Apart from lymphocytes, the toxic effects can affect other systems as well. So it causes deafness, costochondral abnormalities, liver damage, behavioral problems. So ADA deficiency can cause other things along with the SCID. PNP deficiency, that's again another enzyme. It helps in conversion of inosine to hypoxanthine and guanosine to guanine. Deficiency leads to accumulation of metabolites, deoxyguanosine and deoxyguanosine triphosphate. That causes toxic effect on lymphocytes. Apart from SCID, or lymphocyte effect, it can also lead to autoimmune hemolytic anemia and progressive neurological deterioration. Reticular dysgenesis is caused by a defect in AK2 or adenyl kinase 2 that leads to absence of lymphocytes and also absence of granulocytes. So that's your reticular dysgenesis. So all three of them can cause T minus, B minus, NK minus phenotype. This is your T minus, NK minus, B plus phenotype. X-linked is IL-2R gamma. That is important for cytokines like IL-2, IL-15, and IL-4, IL-7, IL-9, IL-21. IL-2, IL-7 are needed for T cells, IL-15 is needed for NK cells. Because of the lack of gamma C chain, both T and NK cells are affected because both these cytokines are affected. JAK3 is downstream of these cytokines, so of course it will cause similar issue. IL-7R alpha will cause just the T minus defect rather than affecting, because there is no concern for the NK cells. VDJ recombination, remember this figure from, I think, chapter 8. This is the VDJ recombination where the RAG1, RAG2 make a nick, and then there is a hairpin formation where the Artemis acts on the hairpin opening and end processing, where other enzymes can work, like DNA PKCs and TDT. They add the nucleotides, and then there is DNA repair by the ligase 4. All of these, if there is a defect in some of these RAG1, RAG2, there is a defect in T and B cell formation. So both it's T minus, B minus, NK plus phenotype. Defect in the DNA repair genes like DNA PK, ligase 4, all of these can cause SCID, along with very typical facial features, so microcephaly, facial dysmorphism, defective tooth development, it's called bird-like faces that these patients can have. Omen syndrome. Omen syndrome was previously thought to come from, but the only ones were T minus B minus phenotype, but now we know that there are other gene defects that can lead to this phenotype as well. So hypomorphic mutations in these genes can lead to presence of these autologous T cells that are defective and lead to allergies and autoimmunity. They can lead to lymphadenopathy, hepatosplenomegaly. There is high IgE and eosinophilia. There is a typical rash all over the body. It's called erythroderma. So it's like the red coloration rather than raised rash. So that's the typical presentation of Omen syndrome. Again, that's a type of SCID. So again, we are still talking about SCID, but this is a different kind of phenotype. All right, these are the defects that have they can cause SCID, but some of them can cause combined immunodeficiency that's less severe than SCID. So CD45 defects, CD3 delta epsilon zeta chains, these can cause SCID, but these can also present with milder defect. Our Rho defect can lead to HPV infection or epidermodysplasia verruciformis. TCR alpha chain defect can lead to, again, viral infections, EPV, varicella, autoimmunity, and things like that. LCK can also lead to immune dysregulation and infections. So that's a long list. Here are a couple of other combined immunodeficiencies like ORI1 and STIM1. Here there is a defect in T cell signaling pathway. We had learned about this NFAC pathway. If you guys remember, there is a STIM1 sensor on the endoplasmic reticulum that senses calcium, and that goes and attaches to crack channel in the cell membrane that has a protein called ORI1. Defect in these can lead to myopathy. Remember, associating calcium with muscles. So there is myopathy along with T cell defect. Bare lymphocyte syndrome. There is a defect in MHC class 1, class 2, typically class 2 defect, pathway defect where the processing of antigens is affected. Class 2 MHC is important for presentation to CD4 cells. So if class 2 MHC is affected, there are reduced CD4 T cells. Remember, MHC class 2 are HLA, DM, DQ, DP. So these would be affected and lymphocytes would not have CD4 on them because of that. So again, these patients present early in life and would be fatal unless it's treated with stem cell transplant. MHC class 1 is a defect in class 1 MHC pathway. Class 1 MHC is required for CD8 cell development. Because of that, the CD8 cells are low. Defect is in TAP1 or 2 or TAPACIN. And these patients present with necrotizing granulomatous skin infections or lesions and respiratory tract bacterial infections. ZAP7T defect can lead to, again, low CD8 T cells, zeta-associated protein 70. Remember, this is an important part of T cell signaling. Here, the CD4 would be normal, but CD8 is affected. UNC119 causes low CD4, but normal CD8, the reverse. These patients present with recurrent viral and fungal infections. 22q deletion syndrome, defect is in 3rd and 4th pharyngeal pouches. So lots of midline defects are noted with thymus defect, parathyroids, heart defect, cleft lip palate, typical feces. The main gene that has been associated with this deletion is TBOX1 or TBX1. Important for you guys to memorize. TBX1 is the main gene that has been associated with 22q11.2 deletion syndrome phenotypes. But of course, there is a lot more to learn about and unknown about the various phenotypes in this syndrome. If less than 1% of these patients can have absence of thymus or congenital athymia, those patients need thymic implant versus the rest of the 99% or more than 99% of the patients just need supportive therapy. Apart from that, there are some other defects that cause congenital athymia, like FOXN1, that also causes alopecia and nail dystrophy, coronin 1A, that that can also lead to T cell defect, MST1, another combined defect syndrome called Viscott-Aldrich. Defect is X-linked due to VASP gene defect. There is also autosomal recessive form caused by VASP interacting protein or VIP gene defect. These patients these patients have defect in this protein that helps in actin cytoskeletal rearrangement, so the movement of the cells. And so these patients typically present with a triad of symptoms: eczema, thrombocytopenia or small platelets, and recurrent infections. Treatment is stem cell transplant or gene therapy is available on research basis. Hyper IgM syndrome defect is caused by lack of communication between T and B cells. T cells help B cells switch from making IgM to GA or E. If the class switching is affected, you get hyper IgM syndrome. Here they can have severe infections, bacterial, opportunistic infections. The response to vaccines is abnormal. Treatment is stem cell transplant. The defect in CD40 ligand, CD40, that's the second signal that helps in communication between T and B cells. That causes hyper IgM syndrome. Now that's your typical hyper IgM syndrome with T cells affected and opportunistic infections. However, AID-UNG can be affected where the communication between T and B cells is normal, but the B cells class switching mechanisms are affected. These are the enzymes needed for class switching. If those are affected, it's a pure B cell defect and you do not see opportunistic infections. So in those cases, there is a defect in this class switching process that we had learned about, and there is lymphoid hyperplasia versus CD40 ligand looks like SCID, and there is lack of lymph nodes. So that's the difference between the two types of hyper IgM. Hyper IgE syndrome caused by several gene defects, important ones STAT3, DOCK8, but there are others that you have to know about: PGM3, Comel-Netherton's, caused by SPINK5, Urban, CARD11, Loeys-Dietz syndrome, ZNF341. STAT3 is called Job syndrome. It has this coarse facies that's been noted for some of these patients, and these patients present with lots of allergic issues, high IgE, along with severe infections. Ataxia-telangiectasia is caused by defect in ATM gene, and it of course has other problems like neurological defects and risk of cancers. HLH syndrome is caused by a defect in formation of these or transport of the granules to the periphery that can lead to various defects at various stages. There's also some syndromes like XLP, X-linked lymphoproliferative syndrome, that can lead to familial HLH. Right, Shiraki-Higashi is one of those caused by defect in LIST gene. There is defect in phagosome and lysosome fusion, so there are giant lysosomes noted. Melanosomes are also affected, causing partial oculocutaneous albinism, and leads to nerve issues, bleeding disorders, and the typical features of Shiraki-Higashi. Here's a hair strand showing the melanosome causing defect in the melanin pigmentation. All right, now we talk about the B cell defects. If the B cells are affected and making antibodies, you get antibody deficiencies. That's the last part of the discussion today, and then we'll come back and go over chapter 17 next time. So here we go over the B cell defects, where some of these defects will lead to cyanopulmonary infections. Let's talk about A-gamma globulinemia. Lack of mature B cells causes A-gamma globulinemia, lack of immunoglobulins, or response to vaccines. This occurs after maternal immunoglobulin disappears. So around 3 to 6 months of age is where these patients present with severe bacterial infections or viral infections. Treatment is replacement of immunoglobulins. Bruton's X-linked A-gamma globulinemia is caused by defect in BTK. Remember, here is BTK, where we had talked about in B cell signaling. And autosomal recessive form is caused by defect in some of the pre-BCR formation like mu heavy chain, Ig alpha, Blink, PI3 kinase, all of these present with AGAM. Common variable immunodeficiency, B cells are normal in number, but or can be lower in number but not absent. Lack of immunoglobulin absence or low IgG along with low IgM or A or both leads to a poor response to vaccines. These patients present after 4 years. Let's just say 4 years of age. Sorry, I should change that. And then these patients present with lots of bacterial infections, viral infections, protozoal infections. They can also present with non-infectious issues mentioned here, and that's how it gets the name common variable immunodeficiency. Treatment is immunoglobulins, but also you may need immunosuppressants for complications. Defect in several genes has been associated with CVID, like TACI gene, ICOS gene, inducible co-stimulator is ICOS, CD19, CD81. Remember, these are part of the BCR. So those are affected, they can lead to CVID. All right, selective IgA deficiency. TACI defect has been associated with selective IgA deficiency, but it's just an association. These patients have normal B cells, normal other immunoglobulins, and variable response to vaccines. They may be asymptomatic, but they can have lots of infections or autoimmunity and can evolve into CVID. Diagnosis is made after 4 years of age, and treatment depends on the presentation, monitoring versus treatment with prophylactic antibiotics. Rarely they may need immunoglobulin, but typical treatment is prophylactic antibiotics. Specific antibody deficiency, normal B cells, normal immunoglobulins, but response to vaccines is low. This can be part of another immunodeficiency, and treatment again depends on whether they are symptomatic or not. You can give them extra booster doses of conjugated vaccine, prophylactic antibiotics, or immunoglobulin replacement. And then transient hypogam of infancy. These patients have normal B cell counts, normal response to vaccines, but their immunoglobulins are low. This is booked because the maternal immunoglobulins disappears from their circulation by 6 months age, and at that time there is a nadir in the immunoglobulin levels. In some patients there is lag in the baby's immune system to take up the job and start making antibodies, and that lag can last up to 2 to 5 years of age. So that causes transiently low immunoglobulin, giving the name transient hypogam. These patients are mostly asymptomatic. If they do have recurrent infections, they may need treatment. All right, that was the last slide.